Hi everyone. Hi everyone. I hope you're able to see the screen. So today we'll be discussing about oral radiology. It's going to be like a revision class. So I would like you to be a little more interactive if there's any questions, so that if you have any doubts also, please feel free to let me know so that we'll stop, we'll discuss, and then we'll proceed on. Okay. So whenever you're preparing for oral radiology, I would want you to focus on a few topics. So, before that, starting with the person who discovered this concept of radiology, Sir William Roentgen. So, you know the date of the discovery of X rays, right? November 8th, 1965. So, this was when he discovered this X rays, and this might be an MCQ for you. Okay. Just a second. Okay. So these are the topics that you have to cover. Make sure keep it in your mind when you're preparing for revision for your oral radiology. Okay. So the first thing that you will be reading about is your basics. That is going to include your X-ray tube head, your power supply and stuff, and then you have to worried about the X-ray films, your sensors, your 2D, 3D, everything. Okay. So once you read about your sensors, we need to know about the processing of the X-rays, right? And this also is going to include your techniques for taking those X-rays, be it an IOPA or a bite wing or a OPG or cephalogram. So this is going to include your techniques of X-rays. This is also including your object localization techniques, your slop technique and all that. Okay. Then comes your interpretation. Once you have the X-ray in hand, you have to interpret it, right? So we have to know what is normal to differentiate it from the abnormal pathologies. So interpretation is very important. Okay. So following that, we all know X-rays are good for diagnosis as radiotherapy. It is used in intervention also, right? But it has its own side effects, right? So sorry, just give me a second. Yep. So we have to know about the radiation protection, which includes for both the patients as well as the personnel who's taking the X-rays. Also, apart from the normal and the pathologies, we need to know something called as artifacts. So these are nothing but faulty radiographs. The reason why we should know what are faulty radiographs is sometimes this can hinder with the diagnostic quality. So sometimes we can interpret it as any pathologies, right? So we need to know what are the faulty radiographs and how to avoid taking those faulty radiographs, or these are called as artifacts. And apart from it, I'll also be emphasizing on a few key points that you have to remember in case of your radiology MCQs. Okay. So starting with the basics. Okay. So your electromagnetic spectrum is going to include your waves, that is starting from your radio waves, your microwaves, your IR rays, visible light in the middle. Then you have your ultraviolet, X-ray, and your gamma rays. The key point that you have to remember here is whenever there is an increase in the wavelength, there is going to be a decrease in the energy. You can see the arrow mark here, right? So there is going to be an increase in the wavelength from your gamma rays to your radio waves, which means your radio waves is going to have a maximum wavelength, okay? But the energy is going to be inversely proportional to your wavelength, which means your radio waves will have a maximum wavelength but the minimum energy. On the other hand, your gamma rays will have a minimum wavelength but have a maximum energy. Okay, so this is the electromagnetic spectrum. Remember, it starts from the radio waves to the visible light and then to the gamma rays. Okay, and your non-ionizing radiation is going to include your radio waves and your microwaves and all that. Yeah, so this was one MCQ asked among the following, which is non-ionizing radiation, which is going to include your UV rays. Okay, and the other non-ionizing radiation will be your visible light, infrared radiation, microwaves, and your radio waves. You all know radio waves, right? Which is used in ultrasonography, your USG. So these are the non-ionizing radiation. Remember the ones before the visible light, ones before the visible light. That is your infrared rays, your microwaves, your radio waves, and your UV rays. All these are non-ionizing radiations. The one beyond your visible light is going to be your ionizing radiation, your gamma rays, your X-rays. All those are going to be ionizing radiation. Okay. Okay. So moving on to the X-rays, we all know that fast-moving electrons from your cathode, when it hits on the anode, yeah, X-rays are going to be produced. So moving on to the radiation physics, which is going to include the X-ray equipment. Okay, so the X-ray machine consists of two main parts: the tube head and your power supply. Okay, so these are the parts of your tube head. Okay, the first thing is your tungsten cathode. which has a filament which is going to be heated up by an alternating current, and then it is going to generate some electrons. Okay, so these electrons are being focused by using a focusing cup. Okay, so this focusing cup is made up of molybdenum. Okay, and this focusing cup is going to focus the electrons to hit directly on the anode. On the other hand, if you see on the anode also there is tungsten only, and it is embedded within a copper block. See, whenever these electrons are going to hit on a target, what will happen? More amount of heat energy is also going to be produced. So it has to be dissipated, right? For that purpose only, we have this copper block, which is enclosing this tungsten at the anode. The reason for having tungsten at the cathode and the anode is for four main reasons, okay? First is it has a high atomic number. If it has a high atomic number, then more number of electrons will be produced. Second thing is it has a high melting point, so it can withstand much amount of heat. Also, it has a high thermal conductivity. And the last is it has a decreased vapor pressure. For these four main reasons only, we are going to have your tungsten at the anode. Okay. So it has to produce large number of electrons, and it has to withstand the high amount of energy that is being produced with a high melting point and increased thermal conductivity and decreased vapor pressure. These are these are the reasons why we are having tungsten at the anode. And when these fast moving electrons are going to hit at the anode, your X-rays are being produced. Okay, remember that point. So the point at which this electrons is going to hit is called as the focal spot. Remember, there are two focal spots at the anode. One is the actual focal spot, second is the effective focal spot. The size of your actual focal spot is 1 into 3 millimeters. Okay, so the actual focal spot is it is going to the divergent X-ray electron beam is going to not the X-ray electron, the electron beam, the divergent electron beam is going to hit on the focal spot at between that 1 into 3 millimeters. Okay, so this is the actual point where it is going to hit. To make it more effective, that is to make it more precise, so that it is going to focus the electrons and produce good quality of X-rays. For that reason, what we are going to do is we are going to decrease the size of the focal spot. Okay, so we are going to create an effective focal spot that is going to measure in 1 into 1 millimeter. Okay, it is lesser than the actual focal spot size, so it is going to increase the fineness of your final radiographic image. Okay, a finer image is going to be produced, and also it is going to decrease the chance of film fogging, and also your low density photons will be removed. Okay, so actual focal spot 1 into 3 millimeter, effective focal spot 1 into 1 millimeter, remember. Okay, and then your anode, right? If it is static at one position itself, then the fast moving electrons are going to hit at the same point. So more amount of heat is going to be generated, right? So to dissipate that heat, apart from having that copper block, we can also make it a rotating anode. Okay, when we rotate the anode, what will happen? It will hit at different points at each exposure, right? So that time, what will happen? The amount of heat generation is going to be slightly minimized. Okay, so this is the difference between your rotatory and the stationary anode. This concept will be applied in another area also. I will tell you where. Okay, and then vacuum in the chamber. The reason why we should have a complete vacuum in the chamber is if there are some other particles that is being present within that evacuated glass chamber, then what will happen? The collision is going to happen between the incoming electrons and the particles that is present within the glass chamber. So to avoid that collision only, we have to have a complete vacuum within the glass chamber. So these are the points that you have to remember when it comes to the tube head. Okay, you have an MCQ here. Which of the following converts the electrons into X-rays? You have four options: a positive anode, a negative anode, a positive cathode, a negative cathode. Can anybody tell the answer? Or maybe just at least guess it. There are two mistakes in this question and two correct options. And within that correct option, only one is the correct answer. Anybody wants to make a guess? Very good. Okay, so Amar has got it right. The answer is positive anode. Actually, the two wrong options are the negative anode and positive cathode. See, as you can see in the previous picture, no? Sorry. So in the previous picture itself, I had mentioned the cathode is negative and the anode is positive. So these two are the correct options. So amongst that, the question that was asked is which converts the electrons into X-rays. So we all know the anode is the part which is going to convert the electrons into X-rays. So the correct answer will be a positive anode. Okay. Okay, so moving on to the power supply. When it comes to the power supply, we all know the tube current, that is the current that is flowing through the tube. And the tube voltage, that is the potential difference between the cathode and the anode, which helps in the movement of the electrons from the cathode to the anode. And your timer is to for measuring the radiation exposure, and your tube rating and duty cycle have a role in the main I mean the significance of your tube rating and duty cycle is to produce a successive exposures. After one exposure we should give a time difference, right? Or we should give a gap to again produce another successive exposure. Only if we give a time gap, then what will happen, if we don't give a time gap, then what will happen is the machine is going to be heated up again and again, and it is going to get fatigued. So we have to avoid that. For that only we have these two terms, tube rating and duty cycle. Mainly it has a significance in the successive producing the successive exposures of the radiation, okay, without damaging the X-ray machine. Okay, there was one MCQ asked pertaining to your power supply. The transformer used to heat the tungsten filament of the X-ray tubes. You had four options for it: a step-up transformer, auto transformer, transducer, and step-down transformer. See, always remember you have a auto transformer and also a step-down transformer that is infused within your X-ray machine. Okay, the main thing is what they have asked is the transformer that is used to heat the tungsten filament. That is the process that is happening at the cathode. We have an alternating current, that is incoming alternating current, right? Sometimes what will happen, it will have a high amperes, okay? So if we have a high amperes, what will happen, it might heat up the filament to a greater extent. It can damage the coil very easily. So for that we need to have a step down transformer to cut down the power supply of the incoming alternating current. It has to step down the incoming voltage to make it more optimal for the tungsten filament to get heated up, okay? And then you will have this auto transformer in the middle, okay? When there is a potential difference between created between your cathode and anode, there and all, your auto transformer will be present. But initially at the place where you have to heat the tungsten filament, your step down transformer only comes into play. So the answer for this is option B, okay, step down transformer. And one more thing we have to remember is for your IOPA machines and as well as for your OPG and SF machines, no, the ideal tube current is going to be between 8 to 9 milliamperes, and for your kVp is going to be between 70 to 90 kVp. Okay, when it comes to your high-end machines like your CBCT and your CT and all, CPCT also, I think it can be taken with your OPG machine itself, only with the change in the settings, that's all. But your CT and all will require a high tube current and a high voltage, okay? Because those are high-end machines, it has to take has to go through or slice the entire body. So in such cases, the kVp is going to be more than 120 also sometimes, and your milliamperes also will be definitely more. Okay, I think it's between 12 to 15, I'm not sure. But for your IOPA and your OPG machines, it is going to be the same almost. Okay, so your milliamperes, your tube current is going to be between 8 to 9, and your kilovoltage potential will be mostly between 70 to 90. Sometimes the settings can be changed also. Certain machines will have, it can have a settings to that is different for pediatric patients and for adult patients. It will reduce the kVp and MA settings for the pediatric patients, and it will be slightly increased when it comes to your adult patients. In adult patients also, it will have certain categories where you might have to alter it in case the patient is slightly obese, no? So in certain cases, we might have an altered settings also, but that is there only in a few machines. It's not there in the commonly used ones. Okay. Okay. So I think the production of X-rays, you all will be familiar with these two terms, right? The Bremsstrahlung radiation and characteristic radiation. So these are the ways in which your X-rays are being produced. We all know from the electrons are going to come from the cathode and it's going to hit on the anode. But the process that is taking place in between at an atomic level is what is explained by your Bremsstrahlung radiation and your characteristic radiation. Okay. And then there are certain things that we have to remember when it comes to the factors that control the X-ray beam. First is the exposure time. Remember, the exposure time is always proportional to the number of X-rays that is generated, okay? But the range or the energy of the X-rays will be constant. It is not going to be controlled by your exposure time. Only the number of your X-rays that are being produced is going to be controlled by your exposure time, okay? Second thing is tube current. We all know, right? The milliamperes, the tube current. So again, this also is going to be proportional to the quantity of radiation. So these two, no, these are going to influence the quantity or the number of X-rays that are being produced, but the quality or the energy is going to be constant. Whereas your tube voltage, if you see, no, whenever there is an increase in the tube voltage, it is going to increase the number of photons. Also, the energy of the photons is also going to be controlled by this. Okay, so this is also going to influence the quality of radiation. Okay, apart from the quantity, your tube voltage definitely has an influence in the quality of radiation. So whenever the kVp is increased, the energy is going to be increased, and it can also go up to the maximum energy of your X-ray beam. Okay, it is going to influence the maximum energy of your X-ray beam. Remember, it has an influence in the quality of radiation. Okay, and then comes your filtration. The importance of filtration is to remove the low energy photons and also to improve the fineness of the image. Okay, so there are three types of filtration: inherent filtration, added filtration, and total filtration. Inherent is something that is already there, like your evacuated glass chamber, your the I mean enveloped glass tube per se. All these the oil that is present around the glass chamber, all these things are the inherent filtration. Okay, added filtration is something that is added to enhance the filtration process. So this added filtration is by the usage of materials like aluminium. Okay, aluminium is the most common material that helps in filtering the low dose radiation. Okay, and the total filtration has to sum up to an equivalent of at least 2 to 2.5 millimeter thickness of aluminium. Okay, so this is your total filtration, which is which sums up your inherent as well as your added filtration. It has to be equivalent to 2 millimeter to 2.5 millimeter thickness of your aluminium. Okay, so this is about filtration. Then comes your collimation. Again, collimation also is to reduce the scattered radiation or the low density photons. And the collimators are of two main types: round and rectangular collimators. Round collimators are the most commonly used ones, but the most preferred one is going to be a rectangular collimator. Rectangular collimator is most preferred because it resembles your shape of your IOPA film, right? So it is going to completely block the radiation, and it is going to give you it is going to reduce the scattered photons. It is going to focus only within the shape of that particular X-ray film. So the rectangular collimation is the most preferred one, but most of the X-ray machines have a round collimator. And then comes your inverse square law. Always remember that intensity I1 by I2 is equal to D2 square by D1 square. Okay, intensity is inversely proportional to the square of the distance. Okay, so this is your inverse square law. So these are the factors that is going to control your X-ray beam. Okay. Which of the following items influence the mean energy? So I just explained it, right? Your kilovoltage potential is going to influence your mean energy. So as your kVp is getting increased, the mean energy of the beam is also going to increase, and it has a chance to attain a maximum energy also. The quality of radiation is influenced by your kVp, and your quantity of radiation is going to be influenced by your exposure time and as well as your tube current. Okay. I hope these points are clear for you. Yeah, there's one more thing that is going to influence the mean energy: the amount of built-in infiltration. Built-in infiltration is nothing but your inherent filtration, right? So this is going to absorb the low energy photons, which again is going to increase the mean energy of the beam. Okay, so there are two things that is going to improve the quality of radiation. First thing is your kVp, and second thing is your inherent filtration. So these two will the inherent filtration is going to absorb the low energy photons, thereby increasing the mean energy of the X-ray beam. Okay. Okay. So which of the following does not apply to filtration of an X-ray beam in a modern X-ray unit? There are four options: decrease the mean energy, reduce the patient exposure by removing lower energy photons, provided by aluminum filter, required to be 1.5 millimeter thickness for 70 kV. Can anybody guess the answer? You have to pick the odd one out. Okay, they are asking which one does not apply to the filtration of an X-ray beam. Just now we discussed, right? Anybody? Okay, so I'll give the answer. The answer is decreases the mean energy of the X-ray beam. Option A is wrong because we all know that filtration of an X-ray beam is going to increase the mean energy. It is not going to decrease. So option A is the wrong one. Okay, so this one also I already told you, right? A rectangular collimation is the most recommended one because it is going to exactly fit the size of the IAPA film and thereby restrict the area of the patient's face and is exposed to the size of the receptor. So it is going to reduce the patient exposure by more than half. Okay, so rectangular collimator is the most preferred one. Okay, photoelectric interactions are highest in. There are four options given for you: enamel, dentin, cementum, and pulp. And we all know that it is highest in the enamel, okay, because the enamel has the highest atomic number. So the photoelectric interactions are going to be highest when it comes to the enamel. Yeah, and one more thing that you have to remember here is the probability of photoelectric interactions is directly proportional to the cube of the atomic number. Since it has a higher atomic number and the cube of it is directly proportional to the cube, right? So it is highest only in the enamel. Okay, so each of the component is, I'm sorry, each of it is a component of inherent filtration except lead-lined PID. PID is nothing but your positioning devices, right? So insulating oil, your glass window and your tube head seal, all these are the parts of inherent filtration except your PID. Okay. When it comes to the interaction of the X-rays at the atomic level, just remember these numbers, okay? And I hope you all will be familiar with these terms: coherent scattering, photoelectric absorption, and Compton scattering. So just remember these numbers. Any one of it can be an MCQ for you, and I hope the concepts are known to you. So I'm not going to explain in detail to you. Okay. Okay. So once the X-rays are being produced, we have to capture it on the other end, right? It's going to pass through the patient and we have to capture it on the other end. For that only we require something called as receptors to receive the X-rays. So the receptors can be of two types: a conventional film or it can be in the form of digital sensors. When we talk about conventional films, we have different speeds of films, okay? D speed, E speed, and F speed films. This applies to both your IOPS as well as your extraoral films, okay? When it comes to your digital sensors, we have two main types: a solid state detector and a photostimulable phosphoplate system. Your solid state detectors are those that is going to include your direct imaging. So direct imaging as in once you expose the X-rays, it is going to be immediately captured on a monitor screen, okay? Whereas indirect imaging will require a mediator, okay? So where it is going to convert the X-rays through a scanning light to produce the final image. So it is going to include your PSP, your photostimulable phosphoplate system, okay? So this is about your digital sensors, okay? So your parts of your X-ray films, your components of your X-ray film packet, we all know, right? An outer envelope covering a black paper and a lead sheet, and then you have your X-ray film. So when you look at the cross section of an X-ray film, you have a super coat on top of it and an adhesive. Between a super coat and your adhesive, you have the emulsion layer. This is on both sides of the X-ray film. Okay, you have a base in the middle and then emulsion on both sides, and adhesive that is going to stick the emulsion to the base. Okay, and then outer thing is going to be your super coat. Super coat is basically to reduce the flexibility of the film and to prevent it from any kind of damage that is caused while opening the film and all that, and also to prevent water contamination or anything. Okay, so this cross sectional is going to be similar to your X-ray intraoral as well as your extraoral films. So the emulsion is going to be made up of your silver halide grains or your silver bromide most commonly. So the emulsion is composed of AgBr. Okay, and then your shape of the crystals can be flat or tubular crystals. This is going to influence your speed of the X-ray film. Um, when you have flat crystals, what will happen? More amount of X-rays will be absorbed, right? So it is going to be quickly producing an image. So the radiation exposure is going to be very less. When there is any kind of some tubular or very thin surfaced ones, or maybe it can be globular structures. So where the surface area is very less, what will happen? Only a little amount of X-rays will be absorbed. So the radiation exposure might be slightly higher. Okay, it's not more, but it's slightly higher when compared to the flat surface ones. So this is the difference that creates the this is the difference that is going to influence the speed of the X-ray film and also has an influence on the radiation exposure. Okay, we all know, right? D, E, and F speed films. So when we compare all the three, your F speed films are the highest. The ones with the fastest speed. Okay, but the most commonly used ones is going to be your D speed films. Your F-speed films have a disadvantage also. That is why we don't have it in common use. Although it has a high speed and also it has reduced exposure, the film quality is going to be, I mean, the film quality as in, I mean, the X-ray image quality is not as good as seen in the D-speed films, okay? Because it does absorb more amount of low density photons also. So because of that, the quality of the image is going to be slightly compromised. That is the reason why D-speed films are most commonly used ones, okay? So the shape of crystals has an influence on the speed and the radiation exposure. This is the point that you have to remember here. And your base or your vehicle that is made up of polyester polyethylene terephthalate. Remember PPT, okay? Polyester polyethylene terephthalate. So this is the base that is going to have emulsion on both sides, which is adhered to it with the help of an adhesive and a super coat on top of it. When e-speed films are the ones that you are commonly using it, right? Your IOPA films that you've been using, that is the e-speed film. That's what I mentioned, no? E and F speed, and F speed films we don't use it in most common. E speed is the one that we commonly use. Your I think you all be using your Carestream X-rays, right? Carestream is the brand that I remember. So the most commonly used IOPAs are your e-speed films only. Okay, so this is the shape of the crystals, the image mentioned here, no? These are the flat tubular ones and these are the globular ones, okay? Okay. The photosensitive component of an X-ray film is, you have four options for it, your silver halide crystals, sodium thiosulfate crystals, gelatin, and rare earth elements. We all know rare earth elements are not a part of your X-ray film. Your sodium thiosulfate and your gelatin, obviously gelatin and all is not has a major role to be photosensitive. So the most optimal answer is going to be your silver halide crystals or your AgBr crystals. Halides we know, right? Chloride, bromide, and iodide. Amongst that, bromide is only the most common material that is being infused with silver in your X-ray films. AgBr. Okay. So silver halide is the most sensitive to X-rays as well as the visible light, and sodium thiosulfate is nothing but component of the fixer. And gelatin is used to suspend the silver halide crystals, and it is not radiosensitive, like I already mentioned. And rare earth elements are used in intensifying screens. It is not a part of the, it's not a component of the X-ray film. None of it is component of X-ray film except your silver halide crystals. That itself will give you the answer, right? Okay. So these are the available sizes of your X-ray films. This can also be an MCQ, okay? Remember, keep it in mind. Your occlusal film is going to measure 57 into 76 millimeter. Your ideal IOPA is going to measure between 31 into 41 millimeter. That is roughly 3 into 4 centimeters, okay? And then you have your pediatric films that is going to measure 22 into 35 millimeters, okay? So initially what they did was they had a different X-ray for your pediatric anteriors and your posteriors, but nowadays we use the same thing for both, okay? So 22 to 35 is the ideal pediatric size, and the IOPA films for both IOPA as well as bite-wing radiograph we use the same one, okay? So it measures 31 into 41 millimeters, and your occlusal radiograph is almost double the size, right? So it measures 57 into 76 millimeters. Okay. So this is nothing but a self-developing X-ray film. Okay, so it will have X-ray solutions within here in this area, and you will have the X-ray film here. So once you expose the X-ray, when you push the processing solutions here, and it will start developing on its own. And then when you remove the packet, you have your developed X-ray film. These are self-developing X-ray films. Okay. Okay, screen films. Basically, in case of intensifying screens, no, the main purpose of intensifying screens is to reduce the radiation exposure. The reason why, because these intensifying screens are very, very sensitive to visible light. So what the main purpose of it is, what it'll do is it'll convert the incoming electrons into visible light, and then this visible light will help to process the X-rays. Okay. So the amount of radiation exposure is going to be very less here. Okay. So this intensifying screens, basically it is composed of a base, a phosphor layer, and a protective coat. And these are mostly used only in case of extraoral X-rays, but it's not used in intraoral X-rays. The reason, because your intensifying screens, although they reduce the radiation exposure, they have a drawback. they tend to cause film fogging or reduce the image quality. Okay, so that is why your it reduces the contrast of the image. That is why your screen films are not incorporated in case of your IUPAs, but rather in case of your extraoral films, to reduce the radiation exposure, we try to use the intensifying screen. Okay, and the phosphor layer is made up of rare earth elements, and these rare earth elements is going to include your gadolinium oxysulfide and your yttrium tantalate. Your green color emission is caused by gadolinium oxysulfide, which is activated by terbium. Your blue and your UV emission is going to be produced by phosphorus, that is your yttrium tantalate, which is activated by niobium. Okay, so this is the composition of your screen films. Yeah, and one more thing that I forgot to mention is the screen film combination is there. No, the screen film combination has to be maintained. If it is not appropriate, then what will happen? We get an artifact that is called as mottling. Okay, so mottling of the film will be present in case of mismatched screen film combination. Okay, this was asked in MCQ one. A mottling artifact. All right. So yeah, this I think I already mentioned. No? Sorry, which is the disadvantage of a reflective intensifying screen base. It can result in image unsharpness. Okay, so that is the reason why we are not incorporating it into your IUPA image, your IUPA X-rays. Okay, so once we have kept the X-ray films and all that, we need to know about the technique, right? For that, we need to know about the orientation of the X-rays. We all are familiar with the orientation dot, right? In case of your IUPA films, the the orientation dot plays an important role in positioning your X-rays and identifying the side of the X-ray image. So your orientation dot is also always facing your incisal or your occlusal surface, and it has to be placed. Um, the white color surface has to be placed facing the X-ray tube. Okay, so that is how you will be positioning the X-rays on the buccal aspect. Okay, I'm sorry, on the lingual aspect within the vestibule, you'll be placing the X-ray, and then that all, I mean, the X-rays should always be present behind the tooth. I have seen undergraduate students always taking your X-rays by placing it in the buccal vestibule. There is no point in placing the X-ray film before the tooth. It has to always be present behind the object. Only then you will be able to see the X-rays has to hit on the object, and then only, I mean, hit or pass through the object and then only hit on the film. There's no point in placing the X-ray film before the object, right? So it has to be always placed behind the tooth. Remember, it has to be present within the lingual vestibule and not in the buccal vestibule, with the white color surface facing the tube head. It's a very, very important practical point. Okay, I have seen people making mistakes in this basic thing. Okay, so this white color surface should place the X-ray tube, should face the X-ray tube. If it is present on the reverse, what will happen? You have your lead foil on the other side. So because of that, you have chances of presenting an artifact when your shadow of your lead foil will be present like a track, rail track appearance. That will be tire track appearance. That will be seen in embedded on your final X-ray film. Okay, so that has to be avoided by orienting it properly towards the radiation exposure. And when it comes to your extraoral films, no, this is your cassette. This white color thing is your cassette within which you are placing your X-ray film. And sometimes what we do is we try to mark the right or the left side when it comes to your skull radiographs and all. No, skull radiographs, as in I mean your you have sides, right? Sometimes the pathology will be there on the right side or the left side. So to identify the right side or the left side, we sometimes what we used to do is we roll a small slice of lead foil into the shape of L, and then we used to place it either on top or at the bottom, so that we'll be able to identify the side of the image being taken. Yep. Okay. Okay, so latent image formation. So once you expose the patient to some amount of X-rays, what is actually happening? The X-rays are passing through the patient. That is when we read about the interaction of the X-rays with the atomic level, and depending on the density of the object, your bone or your soft tissue, the X-rays are going to pass through the tissue and going to hit on the film. So immediately when it hits on the film, it doesn't produce the final image. There will be a latent image or a ghost image, something like a blueprint that is being produced. Okay, and these are the steps in which your latent image is being formed. I think you'll be familiar with this. So latent image is nothing but like a ghost image or a blueprint image. Only after processing this latent image will you have the final image for diagnosis. Okay. So once your latent image is produced, the next step is going to be processing. So this film processing is going to include two main things. In the manual film processing and the automatic film processing, the solution is going to be same. Only the technique or the machine is going to be different. Okay. So the film processing solution is going to include your developer and your fixer solution. So developer consists of three main components: your developer, activator, and your preservative. Fixer has four components: clearing agent, acidifier, preservative, and hardener. See, the when they leave you inside the dark room, no, sometimes you don't know where the developer is and the fixer is. You might get confused, or you don't know how to identify it, right? So when always when you touch your developer solution, it will be slightly soapy in consistency. You'll feel it like slightly. It's going to be like you'll feel it like a soap, okay? Because the developer is alkaline in nature, okay? Your developer is alkaline in nature. On the other hand, your fixer is going to be acidic in nature. You can smell that pungency of that acid. So when you smell that as fixer solution, it will be slightly acidic in nature. But your developer solution, it will be soapy to touch. Okay. So because it is alkaline in nature. Also, your developer solution, once you immerse your, your X-ray film is slightly white in, it's like a tinge of blue, right? But it's something slightly white. So when you place it within the developer solution, it will be entirely black. It's like coating the developer solution over the X-ray film. Okay, so it will become completely black. Okay, that is because of the reaction of this phenidone and hydroquinone. These are the developer solutions that is going to go and coat the areas wherever the x-rays have been captured, wherever the latent image it has produced an outline. No, this will go and coat the entire area. Okay, it has to develop the x-rays there. Okay, the silver halide grains there. So this phenidone and hydroquinone are important for that action, and this has to be activated, right? It is alkaline in nature. It needs an activator. So for that, your sodium or your potassium hydroxide will activate this phenidone and hydroquinone to develop the X-ray film. And to prevent the solution from being spoiled very early, you have a preservative that is in the form of sodium sulfite. Okay, so this is applicable for your both your powder as well as your liquid developers. You know, right? It is available in the powder form as well as in the liquid form. So your preservative here used for your developer solution is sodium sulfite. Now your X-ray film has become very black in color. And then what you have to do, you have to immerse in the water to remove the excess solution. Okay. After that, what you have to do, you have to place it inside the fixer. The important function of your fixer is to remove the excess developer and also to fix the image onto the X-ray film. Okay. So the first thing, remove the developer. For that, we use a clearing agent. Okay. So the clearing agent in the fixer solution is going to remove the developer from the unwanted areas. Okay. So because the material that is used for clearing as a clearing agent is your ammonium thiosulfate. Okay. So this is a clearing agent to remove the excess developer solution and the areas where it is not needed. Okay, this is going to create that areas of gray. Okay, your developer is going to create the areas of that black in color, the black color areas, and this one is going to create that radio opaque and your gray color areas. No, this is going to be produced by your clearing agent. And as I already mentioned, your fixer solution is acidic in nature, right? And the acidifier that is present in the fixer solution is your acetic acid buffer. Okay, and the preservative that is used to preserve your fixer solution is ammonium sulfate. There it was sodium sulfate, here it is ammonium sulfite. Okay, remember. And then your hardener. The reason why you need a hardener is you have to fix the image onto the X-ray film, right? Because what you're going to do after placing it in the fixer, you're going to place it again in water, right? You're going to wash off the excess fixer solution. So the image shouldn't go entirely. So to fix the image onto the X-ray film, we need something called as a hardener. Okay, ammonium sulfate is the hardener. Okay, so I hope you're clear with the processing components of the processing solutions. See, any one of it can be an MCQ, and the pH of your developer and fixer might also be asked. So always remember it, okay? I think in the previous question papers, they had asked about the preservative things, and also they asked about the activators, I think. These two were the most commonly asked ones in the previous year papers, okay? Remember the components of the processing solution. Okay. So when it comes to processing, one more thing that we know is your X-rays is very very sensitive to bright light. So when once you open the X-ray film, what happens? If you open it in bright light, it immediately will get processed. So to prevent that, we have to develop it within a dark room. So the dark room equipment consists of a red filter that is the safest thing to prevent the immediate exposure of the X-ray film. So the dimensions, I hope you all are familiar, right? The red light has to be placed 4 feet above, and the voltage of it should be 15 watts. Okay. So this is the darkroom equipment that is necessary for processing your X-ray film. This applies for both your manual as well as your automatic processing. In automatic processing, there will be a red color shield that is present on the automatic machine. I'll show you. So below that only we'll be processing, opening the packet, and we'll be sending it into the processor. And the test that is used to confirm the safeness of the darkroom equipment is your penny test. I hope you all are familiar with the penny test, right? Where you have an X-ray film, you place a penny on top of it. In open white light, you will be placing it, and then you'll be processing it. If there is going to be a light area that is produced on the X-ray film, then it means that the safe lighting is not good. Okay, that is which means it is capable of producing film fogging. So you have to change it. Okay, so this is your penny test for testing the darkroom. Okay, so this is your manual processing. You have developer, water, and then your fixer solution. You're going to process it manually. The second thing is your automatic processor. In automatic processor, you have your place where you insert. This is the red color thing that I mentioned. So you'll be placing the film under this red color light only. You'll be opening the sachet. You'll be taking the film and you'll be placing it here, which is going to move through these turbines. So the film will be inserted here. It will get dipped into the developer. Automatically, it is going to fall inside the fixer, and then it will move through the water. It will get washed off, and it will have a rack for drying, and then you'll when the final film is coming out, it will be completely dry. You don't have to do anything manually here. Okay, the difference between your manual and your automatic is it is first dipped in the developer, water, and then fixer, but in the automatic it is developer, fixer, finally only it is going to be water. Okay, so this is about the two techniques of processing your X-ray film. Okay. So all those was about the conventional images, right? When it comes to digital, this person, Dr. Francis Moen, he has an important role in developing the digital sensors for completely digitizing the X-ray methods, so that we can reduce more amount of radiation exposure was reduced. And also the most important thing, once you take an X-ray, if there's any corrections like artifacts, some cone cut is there, or if you feel that image is not bright enough, you can never do any corrections, right? Once it is taken, it's just done in case of conventional film. But when it comes to your digital X-rays, there can be certain alterations made. Especially you can alter the brightness and the contrast of the image. You can zoom in and zoom out to have a clearer image. So all these things are advantages of your digital films over your conventional X-rays. Okay, so Sir Francis Moen is the person who is behind the discovery of your digital radiography. Okay, so the digital imaging or digitization is like giving a numeric format to the image content, and this basically the digitization is nothing but giving different shades of gray. Okay, different shades of gray to each of the picture elements. Pixels are nothing but picture elements. Imagine this is going to be your sensor. Okay, so the areas that are dark in color, that is the black color area, or we call it radio dense. I mean. Radio opaque and radiolucent, right? So the radio opaque areas are where your bone is being present. So there it is going to be, the X-rays are going to be attenuated, and only some amount of X-rays will pass through and hit on the X-ray film. The other areas are where in case of your soft tissues, right? So the in those areas, what is happening? The radiolucent areas are like more amount of X-rays are being passing through. So it is going to hit on the X-ray film, and it is going to be slightly darker. So the alignment of these shades from the brighter one to the darker ones, this is going to be computerized completely. Okay, wherever there is bone, this areas with the white color shade is going to be assigned there in those pixels. Wherever there are areas with soft tissues or like pulp, or in case of any pathologies, no, radiolucent areas, in those areas this black color thing has to be assigned there. So this is everything computerized. Okay, that is why it is in a numeric format. Numbers will be allotted to each of these pixels, which will which will be oriented by the computer processing unit to finally give you a image, X-ray image. Okay. So the formation of digital image involves a few processes. First is exposure to X-rays. This exposure to X-rays is going to be same. Nothing, no settings is going to change between your conventional film and your digital sensor. Exposure is going to be the same. The MA, the KVP setting, everything is going to be the same. Instead of an X-ray film, you're going to use a digital sensor. That's all. Okay. And imagine the sensor is having all these small squares or pixels. So each of the pixel will absorb the X-rays depending on the density of the object after it is passing through. Okay. Dense object means only some amount of X-rays will pass through and hit on the pixel. If it is a soft dense object like your pulp or your soft tissue structures like your gingiva, or if there's nothing present, air, in such cases more amount of X-rays will be passing through the tissues and it is going to hit on the particular pixel. Okay, so each of the pixel is going to absorb the X-rays after attenuation from your body. Okay, and then each of the pixel is going to generate an voltage based on the amount of X-rays. Okay, so these X-rays, more amount of X-rays means more amount of voltage, and this voltage fluctuation between the two pixels, no, this is going to create an analog signal. This analog signal will be sent to the computer programming, which is going to finally give you the final radiographic image. Okay, so the analog to digital conversion involves two main processes: sampling as well as quantization. First thing is sampling. What is sampling? The small range of voltage groups are there, no, it will be grouped together. So sampling is something like fusing, right, grouping together. So the small voltage group will be grouped together, and each of this voltage group will be assigned a number is quantization. Okay, every sampled signal a value is going to be assigned. Next thing is computer processing. Like I already mentioned, right? The pixels have to be arranged in the matrix according to the number that is assigned. Like I mentioned, no, radio opaque areas, if it is very bright, means it will be given one number. A black color area, radiolucent areas will be given one number. So according to the number that it has got, the pixels have to arrange itself in the matrix. What the computer only is going to arrange these pixels. Okay. So finally, you will have the image that is being displayed. Okay. The organized pixels will display the image as different shades of gray. Okay. This one I already mentioned, right? The direct and the indirect. Direct, you can see X-ray sensor is here. It is directly connected to the computer. Once you expose the X-ray sensor, your image is going to be displayed immediately. Okay. And then your indirect is going to make use of scanning light, where the sensor is going to pass through this. Your scanning light will process the image and then only your final image will be appearing. Solid state technology is going to involve three: your charged coupled device, your complementary metal oxide semiconductors, and your flat panel detectors. Among these three, your CCD and your CMOS are most commonly used for intraoral imaging, and your flat panel detectors are mostly used for your extraoral imaging, like your CT, CBCT, and all that. Okay, and your photostimulable phosphoplates, we all know, right? PSP. The PSP sensors will be similar to your IOPA films only in the appearance, but the processing is going to be different. Okay, I'm not talking in detail about CCD, CMOS and all. Okay, there's one more thing that we have to remember here, something called as scintillators. Remember the concept of intensifying screen, okay? The concept of intensifying screen is going to be similar to your concept of scintillators, okay? So CCD is sensitive to light, so we use something called as a scintillating material to increase the X-ray absorptive capacity, and the materials that is used for scintillators is your gadolinium oxybromide and cesium iodide. The concept of scintillators is similar to your concept of intensifying screens. Remember that alone. Okay, so these things I already mentioned. Flat panel detectors is used for larger images. PSPs, like I told you, yeah. And one more thing we have to remember when it comes to your PSPs, in case of your CCD and CMOS and all, it need not undergo any kind of eraser before taking another successive image. But when it comes to your PSP, the plate has to be erased and then only the next exposure has to be done. Okay. Otherwise, what will happen? There is going to be overlapping images or double images being produced. So for erasing the plates, we have three main techniques. First is exposing it to intense light exposure. Second is to place it under the viewer light. That is the one where we place the X-ray films and view it. And then you have your automatic plate erasing systems. So those automatic plate erasing systems are the technology that is being present nowadays. Initially, it was not there, but this automatic plate erasing system is going to be erasing systems, it is definitely a higher grade, right? So it can automatically erase the previous image, and then once you take the, the successive exposure can be done immediately. We need not do anything to erase the previous image. Okay, so these things no need. Okay, so when it comes to your PSP, we need to know there are two types of scanners. I told you, right, when it comes to the anode, there was rotating anode and stationary anode. Similarly, there are two types of scanners in case of PSP, a stationary plate scan and a rotating plate scan. Obviously, stationary plate scan means only one sensor can be placed at a time and you have to take. In case of rotating plate scan, multiple sensors can be placed and multiple images can be viewed, right? So definitely it is an advantage here, okay? Similar to the concept of your anode. Okay. There are four main things that comes under your digital detector characteristics, which is applicable for your IOPS also. That is the conventional films also. First thing is your contrast resolution. See, contrast resolution is the ability to distinguish between different density. We know that there are different shades of gray, right? Most radio opaque to the most radio sensitive. So there are different densities of the image, right? So to distinguish, the ability to distinguish the different densities is your contrast resolution. Next thing is your spatial resolution. This is the ability to distinguish fine details, that is the closest distance between two closely placed objects. Okay, the distance between two closely placed objects has to be clearly visible in an X-ray. That is your spatial resolution. Okay. Third thing is your detector latitude. That is the ability of the image to capture a range of X-ray exposure. That is your detector latitude. And the last is detector sensitivity, which means it has to be sensitive to even small amount of radiation. Okay. The sensitivity or speed of a detector is the ability to respond even to smallest amount of radiation. This is your detector sensitivity. So these four characteristics are applicable to your conventional X-ray films also. Okay. Remember, contrast resolution, spatial resolution, detector latitude, and detector sensitivity. MCQs were asked from this also. Yeah. The ability of the digital detector to distinguish different densities in a radiographic image is called as contrast resolution. Answer is option B. Okay. Okay, so when it comes to your 2D X-rays, the three main things that we'll be learning about is your periapical, occlusal, and your bite wing radiograph. Okay, this is your full mouth X-ray. Mostly it is used in case of periodontal analysis. No, your full mouth X-rays are the most commonly used ones. Okay, the technique to take your IOPS. You have two main techniques, a paralleling technique and a bisecting angle technique. A paralleling technique makes use of a positioning device. Okay, so where the receptor is exactly parallel to the long axis of the tooth. Okay, so the receptor is placed exactly parallel to the long axis of the tooth, and this is being done using positioning devices, X-ray positioning device. So we even call it as XCPs and all, right? So this equipment will help to position the X-rays um, parallel to the central axis of the tooth and also exactly perpendicular to the central ray of the X-ray film. You can see here, right, the receptor is placed behind the tooth, and you can see that the central ray is passing through the tooth and then only it's going to hit on the X-ray film. Okay, so this is about your paralleling technique. Okay. This equipment is called as an endo ray. Okay. So endo ray is basically used in case of endodontic treatments where you might have to place the files or GPs. Files while measuring the working length, and then GPs while taking the master cone, no, placing the master cone, and then you'll be taking an X-ray. So we need to keep it static. It shouldn't get any kind of movement while taking the X-ray, right? So for that purpose, we use something called as endo ray, which prevents any kind of movement or damage to the X-ray film or to the master cone while taking the X-ray during endodontic treatment. Okay, this is also a positioning device. That is why I placed the image there. Okay, then you have your bisecting angle technique. So this bisecting angle technique makes use of a rule called as Kiesinski's rule of isometry, where the receptor is placed as close to the tooth as possible in such a way that the receptor and the central axis of the tooth are bisected by an imaginary line, and the angle between your receptor and the imaginary bisector and the angle between this line and the central axis of the tooth is the same. Okay, so this is your Kiesinski's rule of isometry. Okay, isometric triangle is being formed here. Okay, between the receptor and the central axis of the tooth. Okay, so this is the projection angles that was given initially. Okay, this was until the eighth eighth edition of your White and Faro, I think. And then the recent one, no, I think 2 years back or 3 years back, there was one first South Asian edition, a blue color textbook. In that one, or I think a black color textbook. After that, okay, in that only the angulations were changed slightly. This is the initial one for your bisecting angle technique, the projection angle for this, and this is the revised vertical angulation where it was almost similar to your incisor and your canines, and for your premolar and the molar it was same. Okay, always remember for your maxilla the angulation is in positive, and for your mandible it is negative degrees. Okay, it is almost same for your incisor and canine, that is plus 45 degree. For the premolar and molar it is plus 35 degree. For the mandible incisor it is minus 25, for the canines it is minus 20. Then you have your now premolars which is minus 15, and then you for your molars it is minus 10 to 0 degrees. Okay. Okay, localization techniques. In case of any impacted tooth, or there's any odontome, or in case of presence of any thing that is, um, I mean, something that is present behind a tooth, or somewhere it is completely a supernumerary tooth, no? To locate where it is exactly present, we use these localization techniques. There are two techniques that is being used, a Miller's right angle technique, and second thing is the Clark's technique. So the Miller's right angle technique, right? So right angle means there are two X-rays that are taken exactly at right angle to each other. The first thing is you're going to take an IOPA. Okay, once you take an IOPA, you'll be able to see whether the object is present mesially or distally, right? You're going to take an IOPA, object is going to be localized mesially or distally. Second thing is you'll be taking an X-ray that is right angle to the IOP. IOP is taken in this way. So the right angle X-ray has to be an occlusal X-ray, right? Occlusal X-ray is going to be at right angle to your IOPA. So the occlusal X-ray will tell you whether the object is present buccally or palatally, or buccally or lingually. Okay. So this is your Miller's right angle technique. Two X-rays taken right angle to each other. First is an IOPA, second is an occlusal radiograph. Second thing is your Clark technique or your slob rule. Remember, slob is nothing but acronym for your same lingual opposite buccal. Okay, same lingual opposite buccal. It's not an acronym, it's like a mnemonic that you have to remember. Okay, same side lingual opposite buccal. Okay, you're going to take one X-ray that is orthoradial. Orthoradial is ideally positioning the X-ray. Okay, in an orthoradial X-ray, you're going to locate the object between the first and the second premolar. That is the first X-ray that you're taking. For the second X-ray, what you're going to do is you have to shift the tube. Okay, the tube shift technique. That is why it's called as a tube shift technique. You can shift the tube either mesially or distally. Remember, the horizontal angulation is only changing. The vertical should not change. If the vertical angulation is changing, what will happen? There will be elongation or foreshortening. For the tube shift technique, only the horizontal angulation has to change. Okay. For example, if you're moving it mesially and you find the object also to be present on the mesial side, okay, then it means if it is moving on the same side of the tube, then means it is present on the lingual aspect. If you're moving the tube towards the mesial side, but you find the object moving distally, means it is present on the opposite side. That is your opposite side means it is present on the buccal aspect. Okay, that is why same side lingual, opposite side buccal. The other name for your Clark's technique is tube shift technique or your slop technique. Okay. This is about your localization technique. Then comes your bite wing radiograph, where you will be taking your upper and your lower teeth at a single exposure, but only the crowns up to the CEJ will be covered. The entire tooth should not be covered. Okay, ideal bite wing radiograph should not cover an entire tooth. It should cover only the up to the CEJ of the tooth. The main importance of your bite wing radiograph is to locate your proximal caries, and also to locate the alveolar crest level in case of periodontal treatments. Okay, so this is about your bite wing radiograph. An ideal projection should be between 0 to 10 degree, plus or minus 10 degree, but 0 degrees it has to be projected. Okay. Then comes your occlusal radiograph. You have three types of occlusal radiograph for both your maxilla as well as your mandible. You have your anterior, cross-sectional, and your lateral. Okay. Anterior maxillary occlusal is going to be like through the bridge of the nose. Okay. So it is going to be focused at plus, I'm sorry, anterior is going to be through the tip of the nose. I'm sorry. Anterior is going to be through the tip of the nose at a plus 45-degree angulation. Then comes your cross-sectional maxilla, which is going to be through the bridge of your nose. Central X-ray is going to be through the bridge of your nose, positioned at plus 65-degree. Okay, and your lateral is towards the side of interest, be it right or the left side, towards the side of the interest, 2 centimeter below the lateral canthus of the eye, and the projection is going to be at plus 60 degrees. Okay. When it comes to your mandibular anteriors, it is minus 10 degrees, central ray passing through the tip of the chin. And your mandibular cross sectional is exactly perpendicular to the film, that is at 0 degrees, midline through the floor of the mouth, 3 centimeters below the chin. And then when it comes to your lateral occlusal mandible, it is going to be 3 centimeters lateral and 3 centimeters below the chin, okay? And it is going to be exactly perpendicular to the X-ray film, again at 0 degrees, okay? So these are about the three types of occlusal radiographs, so both the maxilla as well as mandible, anterior, cross-sectional and lateral. Okay. So when it comes to your 2D extraoral radiographs, it is going to include your OPG, your SEPT, your skull radiographs and your ultrasound, okay? So these are produced with the same X-ray unit as used for your IOPA machine. For the set, the size of the radiograph is 8 into 10 inch, and your skull radiograph it is 5 into 7 inch. So the marking in the marking of the right and the left side is mandatory because it helps to identify the side of the pathology being present. Sometimes you might have condylar fractures, or there might be any kind of bony pathologies. So we need to identify the side, right? Side of the pathology, we have to identify it properly. Then only we'll be able to treat the patient. So the right and the left marking is mandatory in case of your extraoral radiographs, okay? And again, this is also in the form of conventional films as well as the digital images. So this is how an ideal OPG should be present. There are certain key points to remember. The midline structures are flattened and they'll be, the structures of the OPG will be flattened and they'll be spread out, okay? And the midline structures will be present on either side. And air spaces, your pneumatic air spaces and your mastered air space, all these will be seen as radiolucent areas in case of your OPG X-ray. The soft tissue outlines, the soft tissue of your nose, your tragus of the ear, all these also will be embossed on an X-rays, okay? And ghost images, the metallic structures like your dentures, your restorations, your prostheses, your earrings or jewelries, no? All these will be cast as ghost images on the X-ray film. This one I already mentioned, the midline structures like your cervical spine, your hyoid bone, all these will be seen as double images on either side of the OPG, okay? And I have just put a sum up of your extraoral radiographs. This is already there in your textbook, okay? Try to read about the angulation of few specific radiographs and also about the positioning techniques. And I think there will be certain variations and all during the skull radiograph. Like you have your oblique mandible, and then there's some variation between your reverse towns and all, I think. So read about those particular key points alone, and also read about the angulations and the positioning techniques. I'm not telling anything in detail, okay, because it's just a revision class, so I'm not covering it in detail. But I have a key thing for you. Okay. So in MCQs, they might ask you in this way. Okay. They might give you certain structures and which is the radiograph that is being used to view the structure properly. So these are the most common structures and these are the best views for those structures. Okay. Like for example, fracture. This symbol denotes fracture. I hope you all should be familiar with it, right? The fractures of the zygomatic arch and the base of the skull fractures are best identified using a submental vertex view. Okay. Fractures of your zygoma, your maxillary sinus, and your nasal septum are best viewed in a Waters view. Waters view is also called as PNS, okay? PNS view, okay? Or it's also called as an occipital mental projection, okay? And your condylar neck fractures, these are best viewed using a reverse Townes view, okay? Medially displaced condylar fractures are best viewed using a PA view. Coronoid process of mandible clearly seen in a PA skull. Fracture of the ramus and the body of the mandible is seen in a lateral oblique 15-degree view of the mandible. Your horizontally favorable and unfavorable fractures of the mandible is best seen in a lateral oblique 30-degree mandible view. Apart from this, one other key point that you have to remember is when it comes to your PNS view or your Waters view, basically it is to view the sinuses. PNS view means paranasal sinus view. Okay. So the Waters view will try to cover most of the paranasal sinuses except one. Okay. Your maxillary, your frontal, and your ethmoid. All the three will be visualized by your Waters view except one. The except one, no, which the one that is exceptional is your sphenoid sinus. Your sphenoid sinus will not be visible in your Waters view. The X-ray that is helpful in viewing your sphenoid sinus is your submental vertex projection. You have to remember that your PNS view will be able to view all the three sinuses except one, that is your sphenoid sinus. It will give a view of your maxillary sinus pathologies in your frontal as well as your rethmoid sinus, but your sphenoid sinus will not be visible. To view the sphenoid sinus, we have to take a submental vertex projection. Okay. Okay. This is again, I think it was used as a picture-based question, and also they might ask about picture-based question only. Most commonly, it was asked, and it might have a theoretical question also. Okay, basically, this is nothing but a modification of your submental vertex projection. It is called as a jug handle view. Okay, the reason for, I mean, significance of taking a jug handle view is it will clearly show the fracture of the zygomatic arch. Okay, it helps to visualize the fracture of the zygomatic arch. What we do here is we try to reduce the exposure to one third of the normal projection so that the other structures will be blurred out and the zygomatic arch will be highlighted here. Okay. So the zygomatic arch fractures can be best viewed by using a jug handle technique, which is nothing but a modification of your submental vertex view. Okay. And the reduction of your exposure time here, right? This technique is applied in case of your occlusal radiograph also. Why? Because when you're taking occlusal radiograph to view your cellular lith, no, sometimes the lith will not be always a calcified structure. It can be like mucus plugs also. So what we do is we try to reduce the exposure to one third of the normal exposure so that the mucus plugs will be seen clearly. If it is not a lith and if it is the form of a mucus plug, we'll not be able to see in the normal exposure. Okay, it will be just avoided. So you have to reduce the exposure time and then take an occlusal radiograph, and then only you will be able to view those. Okay, so this technique is used in two areas, for your jug handle view as well as to take an occlusal radiograph for your silolith. Okay, just remember. Jug handle view is a modification of a submental vertex projection. Okay, this is another thing that you have to remember. Okay, talking about the TMJ views, so different TMJ views, you have your transcranial, transpharyngeal, and transorbital. Always remember this table. Just read this table. That is more than sufficient to know about your TMJ view. Okay, transcranial means through the cranium, right? So it is taken in two positions: open and closed mouth projection. It has to go through this. Okay, transcranial. It depicts the lateral aspect of the TMJ. Okay, and it displays condylar fractures can be located, and also the range of motion of the TMJ can be seen, not in a 2D view, only to an extent. Okay, and then to identify the osseous changes in case of any eruptive change, I mean the erosive changes and all, no, it can be erosive changes of your articula eminence or the coronoid process or the condyle can be best viewed using a transcranial view. Transcranial view is basically taken in an open and a closed mouth projection. Next is transpharyngeal. It is through the pharynx. Okay, so it is taken only in an open mouth projection, and it is used to view the medial aspect of the TMJ. Okay, fractures of the condyle and the neck of the condyle can be best viewed. Fracture of the condylar neck can also be viewed by using a reverse Towns view. Remember two things, okay? Transpharyngeal view and also your reverse Towns view to view the fracture of the condylar neck. This can be asked in MCQ, okay? And then you have your transorbital. Transorbital is through the eye. Okay, so here it is used to view the entire mediolateral aspect of the TMJ, and it is used for viewing the condylar neck fracture. Again, one more thing, and adjunct as in the diagnosis of degenerative changes or the anomalies of your TMJ. Okay, transcranial, transpharyngeal, transorbital. Okay, remember these three. Okay, USG is nothing but it makes use of sound waves. Here you have something called as a transducer probe. Okay, this transducer probe helps in receiving the sound wave and also reflecting it. Okay, receives the sound waves, passes through the body, and then after passing through the body, sometimes it has to get reflected. Right, it is reflected in the form of echoes, depending on the density of the object it is passing through, and then these echoes will be again received by the same transducer. It will send it to the CPU, and then it will get converted into a black and white image. Okay, this is the principle of your USG. And there's one modification of your USG called as Doppler USG. Basically, it is used to see the hemodynamic abnormalities in case of any AV malformations, or in case we have to see any blood flow in case of your fetal fetal X-rays. That time a Doppler USG will be helpful. These are the modifications of your transducer, and it is modified because it can be taken in different areas. Even you have intraoral USG also, right? So for that purpose only, you have different shapes of those transducers. So the 2D to 3D conversion, the first thing that we have to remember is the pixels or the picture elements there becomes voxels or volumetric elements here. Okay, pixels becomes voxels in case of 3D images. So the 3D extraoral is going to compose of your USG, 3D USG, your CT, CBCT, and your MRI. I'm not going to focus more on the principles of it, just key points alone. Okay. So the difference between your CT versus CBCT, we all know, right? CT consists of a fan-shaped beam and a spiral CT. It has to go in spiral motions completely around the patient's body multiple times, okay, to give you different slices. That is why a CT has increased radiation exposure. On the other hand, if you see the CBCT, it is like a cone-shaped beam that just goes around the patient only one time. In one rotation itself, it will give you the entire field of view, okay. So this is your difference between your CT and your CBCT. CT goes in a spiral motion around the patient multiple times. That is why increased radiation exposure. Okay. Yeah, and one more thing that you have to remember when it comes to your CBCT is these are the points that I already told you. Something called as scan volume or your field of view. Yeah, this parameter can be set. Like you have sectional CBCTs where you can see only 2 to 3 teeth in particular view, and then you can see an entire maxilla mandible. Sometimes even the entire skull can be seen. So the field of view or the scan volume has to be set prior to taking the X-ray, and then you'll be able to see the entire region of interest. The uses are almost same as those of the normal X-rays. Apart from the conventional X-rays, your CBCT is important in your airway assessment, in planning the orthodontic surgeries, in case of 3D cephalometry. See, it doesn't just scan the bone, but also the soft tissues. Your 3D has an important feature where it can even scan the entire facial profile along with the skin and everything, so that it can it can give an appearance of in case of planning of orthodontic surgeries or any prosthetic treatments and all, no, it can give you how it can a three-dimensional view with in the absence of the patient. We can plan everything using a CBCT machine itself. Okay, so basically that is the most important feature that is advantageous over the other x-rays. Okay, that is about your CBCT. MRI principles and all, I'm not focusing. Yeah, when it comes to your CT, this was asked in your MCQ several times. Okay, CT, remember, we have to remember something called as Hounsfield units. Okay, it was named after the person who discovered it. So Hounsfield units are something, a numerical value that is assigned to the amount. I mean, the amount of absorption of X-rays by these particular tissues. Okay, the CT number or Hounsfield units will vary according to the density of the object that its X-rays are being passed through. So your bone is very dense, right? So it will have a highest Hounsfield unit of +1000. Your water has 0 Hounsfield units, and your air has a minimum one. It is in the opposite, that is -1000. Okay, see, I think these three were most commonly asked, and most of the people will tend to confuse between the Hounsfield unit of water and air. Okay, for water, it is neutral. Remember, water, the taste, color, everything is neutral, right? Remember, your Hounsfield unit also is neutral, that is 0. Your air has no density at all, right? So it is in minus. Your bone is +1000 means your air is -1000. Remember it that way. So you won't get confused, okay? Water is always neutral, so it is 0. For your air, it is -1000. Bone is much denser, so it is +1000. In between that comes your soft tissues, your fat, lung, and all. Your soft tissues, the Hounsfield unit is between +40 to +80. For your fat, it is between -60 to -100. And for your lungs with your alveoli, it is -400 to -600. Okay. So in case of your CT, no, you have two modifications, your Voni window and a soft tissue window that can be used. Whereas in case of your MRI, you have sequences to view a MRI. Okay, sequences like your flare sequence, your GRE is another sequence, your PD is your proton density weighing. So that is these are the sequences where you will be setting the MRI machine to view the pathologies. Your T1 sequence will mostly have it will give a look of the anatomical structures, and T2 sequence will give a look of the pathological structures. Okay, so when it comes to an MRI, we'll be speaking in terms of sequences to create the image. Yep, this is about your CT, bone filtered and soft tissue filtered. And then you have nuclear imaging where you use radio opaque isotopes. These radio opaque isotopes will be injected through the patient, and then you'll expose the patient to a gamma camera, which will capture the radioisotopes which has been uptaken by the pathologic structures. And this gamma camera will uptake the radioisotopes and it will give you the final image. So these are the radio opaque isotopes that are most commonly used. I think this was asked in MCQ once. For your bone scan, it is technetium 99M, and for salivary glands, it is gallium. Just remember, okay? And when it comes to your thyroid and all, no, iodine I-131 is most commonly used. Combined imaging. The reason why they combined two images was in case of your PET and your SPECT, that is your positron emission tomography and your single positron emission tomography. These two are nuclear images. The quality of the image or the outline of the anatomical structures were not completely delineated in case of your nuclear imaging. So what they did was they did a fusion imaging. They fused a PET and a CT. We all know, right? CT is the best image, which has a good contrast resolution, good everything, spatial resolution, everything is perfect in case of your CT. The only drawback is it has a high radiation exposure. That is why we don't take it much. We try to avoid it. But this is the best X-ray for outlining your anatomical landmarks. So when you combine your CT along with your nuclear imaging, this is called as a combined imaging or a fusion imaging. You can also see the pathology and anatomical structures. Everything will be completely delineated from the pathology. It will be completely defined. Okay, the detailing is going to be improved. So PET CT, SPECT CT. These are nothing but hybrid, fusion, or combined imaging. Okay, examples. Next comes your silography. Your silography basically is a 2D technique only. First, you will take a scout radiograph without injecting any contrast solution. Okay, scout radiograph has an, if you have any pathology in your salivary gland or your submandibular gland, you will take occlusal radiographs pertaining to it, or any PA view will be taking it. Scout radiograph is without a first initial radiograph. Okay, so after taking a scout radiograph, what we do is we inject contrast solutions through the ducts of the gland that is infected. For example, if you have your salivary parotid gland is being having a pathology, you have silolith in your parotid gland, means we'll inject through the Stensen's duct. If there's any pathology of the submandibular gland, we'll be injecting through the Warten's duct. So through the duct, we'll be injecting contrast materials that will pass through, and it will go and fill up the entire gland. And then you have to take a successive radiograph. Okay, scout radiograph, injection of contrast material, and then a successive radiograph. So when you see after injecting the contrast material, in case there is an obstruction because of a silolith or anything, the contrast material cannot pass through, right? So it will create a difference in the image. And in case of any pathologies like intrinsic tumors, or in case of any in case of what's that? Um, xerostomia, not xerostomia, something else. Yeah, Jogren syndrome, all these conditions, no, so there can be difference in the image pattern caused by the absorption of the contrast material. So this difference in the image is going to be interpreted by using the silographic x-rays. Okay, so I'll tell you how it is being different. Okay, and before that, the contrast materials are of two types. Okay, oil based contrast agent and aqueous contrast agent. It has its own advantages and disadvantage. If you consider an oil based contrast agent, no, it is slightly viscous, right? So the chances of it passing through and then passing out, the ejection of the contrast agent after its purpose is done, no, it is going to be slightly less. So what will happen? It is going to get entrapped within that salivary gland itself, and there are chances of foreign body granuloma to be produced. This is the disadvantage of your oil-based agent. But the advantage is because of its high density, that is your viscosity, it has a chance of being more radio opaque, so it has a good contrast. Okay, so oil based contrast agent will have a good contrast. This is an advantage, but since it the chances of evacuation is going to be less, it has chances of producing a foreign body reaction. On the other hand, aqueous medium means it's watery in consistency, right? So it can easily flow through. Because of its low viscosity, the contrast is also compromised here, but it can easily pass through, right? So because of that, there is no chance of any damage that is caused to the salivary gland per se. Okay, so these are the two types of contrast agent, its pros and cons. Okay. When you look at the silograph appearance, no, in case of a normal parotid gland, when you take a silographic X-ray, when you pass through the contrast agent and then you take an X-ray, it is going to appear like a tree in winter appearance. It has multiple projections, right? So parotid gland, the normal cylographic appearance is tree in winter. See, all these are MCQs, okay? Remember the key points alone. Normal cylographic appearance of parotid gland, tree in winter. Normal cylographic appearance of submandibular gland is bush in winter appearance, okay? When it comes to your pathology, something like a Sjogren's syndrome, you can see that this the ductal tubule is going to be weakened, right? So most of the contrast agent will escape out of it, which is going to create dots or blobs, okay? In case of sialadenitis, wherever there is inflammation of the salivary gland, what will happen? The acinus will be dilated, so more amount of contrast agent will be collected within the tube, and then it will be dilated completely, okay? So this is also appears like a dot or a blob that is within the tubule, and here it is going to be the intercalated ductule is going to be weakened, so escaping of the contrast agent, and the dots or blob will be appearing outside the acinus here, okay? So this is the difference between a normal one, Sjogren's syndrome, and in case of sialadenitis, that is inflammation of the salivary gland. Sialadenosis is, it is not an inflammation, you all know, right? What difference between sialadenitis and sialadenosis? I hope you all should be familiar with it. Okay. So whenever you have a calculi, we know, right, an obstruction is there means then beyond that the contrast agent would not have passed through. So you'll be able to locate the stone in that place. Sialodokitis is nothing but inflammation of the ductal orifice. Okay. So whenever there is going to be sialodokitis, it is going to create sacculation or dilatation of the main duct is going to be present, and because of which it is going to appear like a sausage link appearance. Okay. There is going to be some kind of swelling, and then there is going to be a stricture of the duct, and then again another swelling, again a stricture of the duct will be present, so it is going to be appearing like a sausage link appearance, okay? Sialadenitis, we already discussed. Sjogren's syndrome, it is going to give appearance like a punctate sialectosis or a snowstorm appearance, okay? Punctate sialectasis or snowstorm appearance, where the contrast agent is going to be escaping from the intercalated tubule, it is going to escape to the outside structure, okay? And intrinsic tumors, in case of your mucoepidermoid carcinoma, your pleomorphic adenoma, and all that, no, your intrinsic tumors is going to appear like a ball in hand appearance, okay? Ball in hand appearance. So these are the most common appearances of your stylography. And apart from diagnostics, it is also used in intervention also, where in case of any silolith being present, no, this cannula can be inserted through the duct where it will open up, and then it will engulf the stone and you can pull it outside, okay? So this is the interventional stylography. Okay, so apart from 2D and 3D, we have something called as functional imaging or 4D imaging, where the fourth parameter is time. Basically, it has to helps in capturing the motion of any structure. For example, in case of airways, or in case of TMJ, where the kinetics of the TMJ and all can be assessed. So this is the 4D imaging. I think your ultrasound has a 4D ultrasound is present. You have your 4D MRI and all. These are the advancements that are already present. Okay. Moving on to the radiation therapy. Like I already mentioned, apart from diagnosis, your radiation is also important for therapeutic purpose, where it is used to treat cancers, right? So there are many types of radiotherapy, okay? Radical, adjuvant, and palliative. Remember these three. The basic is any kind of surgery can be treated by three methods, right? Surgery, radiotherapy, and chemotherapy, or it has a combination of all the three. The reason why we use radiotherapy before surgery is in case of large size tumors, what we do is we try to give radiotherapy, shrink the size of the tumor, and then we can excise it easily. Post surgery, why we give radiotherapy is sometimes you have tumors that are more deeply embedded. You can remove only to a certain extent, right? So we do surgery, we remove that tumor entirely, and then we give radiotherapy so that all the positive margins are being completely avoided, okay? All the positive margins have to be completely removed so that the chance of recurrence is being eliminated, okay? So this is use of radiotherapy post surgery, okay? So pre surgery is nothing but your radical, okay? Adjuvant is post surgery, okay? Radical is you radiotherapy first and then you do surgery. Adjuvant is surgery first and then you do radiotherapy, okay? Palliative is in case of helpless or hopeless conditions. You can do no other treatment but just like a supportive treatment. Radiotherapy is given in case of palliative therapy also, okay? Pre-op and post-op is the same. Pre-operative before surgery, post-operative after surgery. The source of radiation again categorizes the radiotherapy into two: external source of radiotherapy, internal source. Okay, external source of beam, if it is given to for radiotherapy of cancers, no, it is called as an external radiotherapy. Internal radiotherapy makes use of something like needles, or it uses some kind of equipments that is that can be placed within cavities or lumens, like in case of your vaginal cancers, or in case of your oral cancer also, no, in case of your tongue, you can place certain needles on your muscles of your tongue, so that it through those needles only radiotherapy will be passing through, and it will go only to specific areas of region of interest alone. So the other areas can be prevented from getting ionized or radiotherapy. I mean, it doesn't get exposed to the radiation. So internal radiotherapy, external radiotherapy. External radiotherapy definitely is a drawback, right? The surrounding vital structures also will be affected, and those also will have side effects of radiation. So internal radiotherapy is preferred in case of any cavitatory lesions, or nowadays in case of smaller sized lesions also internal radiotherapy. It is also called as brachytherapy. Okay. Okay, these are the doses of radiation for the different types of radiotherapy. For radical radiotherapy, that is prior to surgery, it is 65 to 75 gray. For palliative, it is between 20 to 40 gray. And for adjuvant radiotherapy, that is along with the surgery, it is 45 to 60 gray. Okay, this was asked in MCQ once. Okay, one of it was asked, just remember. Okay, the mechanism of action is similar to, see, this thing is similar to the effects of radiation on tissues. I think that will come in the second chapter, no, in biologics of radiation. This is going to be almost similar to your effects of radiation. So, the radiotherapy or the radiation will act on the tissues in two ways: direct and indirect method. Direct is directly damaging the DNA. It can be your tumor cells or the live cells, directly damaging the DNA. Second is indirect, where it uses water as a medium. The water, it is going to hydrolyze the water and then produce free radicals, which is going to go and attach the DNA. Okay, this is the indirect method of mechanism of action. And from this, there is an MCQ for you. This is the cell cycle, right? The G2 phase, M phase, G1 phase, and the S phase. In this, the most common question was, which is the most radiosensitive phase in the cell life cycle? The most radiosensitive phase is the G2 phase. The reason why G2 phase is the most radiosensitive is, we all know, right? We have nucleus that is present in case of the cells, no? From the G0 phase, the G2 phase, if you see, the nucleus will be slightly widened. It will be slightly enlarged or bigger in size. So whenever the target is very clear for you, what will happen? The radiation can go and hit on it easily, right? So in the G2 phase, the nucleus is big, so the target is very easy for the X-ray to go and hit on it. So the G2 phase is the most radiosensitive phase. In the next phase, that is the mitotic phase, what is happening? The X-ray nucleus is going to completely divide, right? Because mitosis is nothing but reduction division. The nucleus will get divided into smaller cells. So, because reduction division is taking place, the nucleus becomes smaller. So, it is the most radio resistant phase. Okay, radio sensitive phase is G2 phase, radio resistant phase is M phase. This was asked in MCQ many times. Okay, remember that. Like I mentioned, most radio sensitive is your G2 phase, most radio resistant phase is your mitosis, that is your M phase. Okay, so always your radiation in an optimal dose is favorable both as diagnostic as well as interventional purpose. So beyond the optimal dose, either it can cause damage to the normal cells, or if it is given more, then it can cause failure to damage the tumor cells also. Okay, so an optimal dose is very, very important. So optimize the dose. There are five main factors that are involved. The total treatment time determines the dose. The number of fractions per day also determines the total dose. Type of radiation, external or internal. The total dose of radiation for the entire therapy, and the dose per fraction of the therapy. Okay. So why we have to fractionate the treatment? Fractionate is dividing the portions of therapy. Okay. So fractionation is for four main reasons: allowing the normal cells to recover post radiotherapy. Second thing is, the tumor cells will move from the radio resistant phase, that is the M phase, and then it will go to the radio sensitive phase, right? So more tumor cell killing can take place. So we have to allow the tumor cells to move from the radio resistant phase to the radio sensitive phase again. Third thing is improving the patient tolerance. So once you're giving some radiotherapy, you have to give some recovery time for the patient. So it improves the patient tolerance for the next successive dose of radiation. Lastly, the chronically hypoxic tumor cells will reoxygenate, and then it can take up more radiation, and more amount of tumor cell killing will take place. So single dose method was earlier used, but now we use a multi-dose method of fractionation. That is, you're dividing the doses between the treatment. Okay, and this fractionation involves 5 R's. Okay, repair, repopulation, reoxygenation, reassortment, intrinsic radiosensitivity. Remember this 5 R's principle for fractionation: repair, repopulation, reoxygenation, reassortment, intrinsic radiosensitivity. Based on the fractionation, these are the different types of radiotherapy. Not focusing more on it, okay, and the different doses of radiation. Yep. This one, like I already mentioned, no, your changes to the DNA post radiation. There can be either breakage of one or both the strands of the DNA, cross linking of the DNA strands can take place, change or loss of the bases of the DNA, that is your adenine and guanine and all are there, no. So the change of base of the DNA can take place, and disruption of the hydrogen sulfide bonds between the base molecules. These are the 4 changes that can take place in the DNA because of excess radiation. And direct effect and indirect effect. Yeah, and I think you all be familiar with your deterministic and your stochastic effect, right? This I think I'm not going to explain in detail, but just remember your stochastic effect is going to cause sublethal damage to the DNA, and your deterministic effect consists of all cells killing of many multiple cells, and the one that is proportional to your dose, that or dose dependent ones, is your deterministic effect. Your stochastic effect is completely independent of dose. It is like in all or none. Okay, all or none response. Either something will be present or nothing will be present at all. I think your example of deterministic and stochastic was asked in MCQ once. Your mucositis resulting from radiation therapy and also your radiation induced cataract formation. These are examples of your deterministic. And when it comes to your stochastic effect, is your radiation induced cancer and heritable effects. You can understand the difference, right? This one depends on the radiation dose, but stochastic effect, it can either occur or it doesn't occur at all. It's like a probability, all or none probability. Yeah, the most radiosensitive cells. I mean, the radiosensitive cells is going to depend on a few things, right? Um, Sorry, I'm not able to do it. Yeah, the sensitivity of the cells depends on 4 main things. 4 options have been given for you. Mitotic future mitotic activity, degree of differentiation, all of the above. Obviously, the answer is all of the above. The radiosensitivity of the cells. Radiosensitivity means it has and it can interact with the radiotherapy. Whenever radiotherapy is being given, it can react to the radiotherapy. So the radiosensitivity depends on the mitotic future, mitotic activity, and the degree of differentiation of the cells. So the most radiosensitive cells, okay, they have been listed here. The most radiosensitive are those that is mentioned here: spermatogenic and erythroblastic stem cells and the base cells of the mucous membrane. And the lowest ones is going to include your brain cells, your neurons, your striated muscle cells, squamous epithelial cells, and your RBCs. When it comes to your organs, no, the most radiosensitive organs is going to include your lymphoid organs, your bone marrow, intestines, mucous membrane, and the least ones is going to be your optic lens and your muscle cells. Okay, the most radiosensitive cell of the following cells in terms of cell killing is going to be your, I think the answer you'll be knowing, no, the basal epithelial cell, most radiosensitive. Okay, this I think this picture will be given in your White and Farrow textbook. I think in your second chapter only. Before acute radiation syndrome, this would be given for you. Basically, it is the duration. I mean, once you start radiotherapy, no, the duration at which your taste loss will start and how long it will be present, and then how after which it reverts back. Your mucositis. See, mostly these two are reversible. Okay, after a particular time, this can be reverted back to normal, but in case of radiation caries and all, no, there's going to be destruction of the tooth. It is complete like an irreversible damage. And in case of your osteoradionecrosis also, no, the bone is completely damaged there. So it sometimes your osteoradionecrosis, it is a permanent or irreversible damage. But your hyposalivation and all, no, you can it is not reversible, but you can give some supplements to alleviate the salivation. Okay, so these are kind of permanent damages only, but these two are like reversible conditions. So you have to note the duration at which it starts. Sometimes MCQs can come like which is the first side effect of radiotherapy, and which is reversible or irreversible. These can be asked. Pilocarpine, yes, it is used for improving the salivation. That's right. But pilocarpine, I think. we don't use it much because there are certain side effects of pilocarpine also. We try to use your artificial this thing, artificial saliva is there, no, the sprays and all that. We try to give only those to the patients. Okay, moving on to the acute radiation syndrome. So, acute radiation syndrome is the manifestation of symptoms that is pertaining to the dose of radiation during radiotherapy. Okay, it's like the signs and collection of signs and symptoms experienced by the patient after the body is exposed to exposure of radiation. Okay, when there is an exposure to 1 to 2 grays, then there will be slight prodromal symptoms only, like mild fever, fatigue, malaise, and all that. When the dosage is slightly increased to 2 to 4, patient experiences mild hematopoietic symptoms. That's like beginning of anemia, and all those will set in. When case of 4 to 7 grays, when the patient is exposed, severe hematopoietic symptoms like exposure to infections, because even the WBC count also will go down, no? So because of that, exposure to infections also will be present. And 7 to 15 grade, the patient will start manifesting GI symptoms. Sometimes gastrointestinal ulcers also will be there, and because of variations in the gastric fluid secretion and all that. Okay, and when the dosage increases to more than 50 gray, what will happen, the cardiovascular and the CNS manifestations will start to set in. So the four responsive stages are: the first is the prodromal phase, second is the latent period, third is the manifestation of illness. Once the patient is treated at this stage, the chances of lethal damage is going to be reduced. If the patient is not treated at the correct stage, then what will happen is the recovery, instead of recovery, the patient will go into a fatal illness. Okay, patient will die mostly. Okay, so these are the four main responsive stages of your acute radiation syndrome. So the treatment, if you see, no, I think one MCQ was asked from this. You use something, a drug called as filgrastim. So this filgrastim, no, is most commonly administered to prevent the infections because of the decreased WBC count. No, we use this filgrastim as a parenteral infusion, and it is administered during the first 2 days of your radiotherapy. This was asked in MCQ once, if I'm not wrong. Okay. Yep. Susceptibility of the different organs to radiation-induced cancer. So these organs have a high chances of radiation-induced cancer, like your colon, your stomach, lung, bone marrow, and the female breast. And the chances of low susceptibility to radiation-induced cancer include your bone surface, your brain, salivary glands, and your skin. So from all these things, no, we can get one point clearly, right? Your brain cells are they are not radiosensitive, and they don't have a susceptibility to radiation-induced cancer also. In very rare cases, only your brain cells or your neurons are being affected. They don't show much of an interaction to the radiation exposure and all that. Okay, so the average dose for your dental professionals who are occupationally exposed is, the answer I think is zero point 0.4. No, zero point 0.2. Yeah, it's between zero point 0.2 to zero point 0.4. The average dose for your dental professional who is occupationally exposed to your radiation is about zero point 0.2 millisieverts or zero point 0.4 of the allowable exposure. So this is the guidelines given by the National Council of Radiation Protection and the International Commission of Radiation Protection, where they have mentioned the optimal dosage for the occupational, that is for the personal and for the patient as well. Okay. So this has to be maintained. For in case of occupational, that is for the personal, what we do is we try to measure the amount of radiation dose using something called as devices, right? Your dosimetric devices. Where is it? So yeah, your personal protection devices, your dosimetric devices, you measure it using your TLD badges, thermoluminescent dosimetric badges, which is in the form of your watch also, or in the form of ring also. Okay, so what they do is once in 3 months we tend to send these TLD badges to the centers where they will measure the amount of radiation dose that the person has been exposed to. In case of persons who are giving radiotherapy and all, there is the exposure is going to be more when compared to the diagnostic radiation. The interventional is more, right? So in such cases, what we do is these people, when they are exposed to more amount of radiation, they will try to give a break for these people for about like 3 to 6 months, and then they will take a break from the radiation exposure, and then they'll be back to work again. They'll be in rotation work, okay, so that they don't get affected by these radiation. Okay. And when it comes to dosimetry, I think this table is very, very important. You have to know each and every terminology and the meaning of each and every terms, and the the SI units. This was asked in MCQs a couple of times. Okay, so the dosage of exposure we all know, right? It is in the measured in the form of coulombs initially. Now it is measured in the form of Roentgen. So it's nothing but a measure of the radiation quantity. Absorbed dose is measured in the form of Gray. It measures the ionizing radiation absorbed per unit mass of the structure. Equivalent dose is to compare the biologic effects of different types of radiation on the tissues. Effective dose is the equivalent dose weighted by the radiosensitivity by exposed tissue or the organ. And then you have radioactivity, which is initially measured in the form of becquerels. Now it is measured in the form of Curie, a person who discovered it. Marie Curie, Madam Marie Curie. So this describes the decay rate of the sample of radioactive material. Okay, so this is about your dosimetry, your different terminologies used in dosimetry. And this is nothing but a table that summarizes your quality assurance on a daily basis, what has to be checked on a weekly basis, your monthly basis, and a yearly basis, what has to be checked and how to prevent the infection control. Okay. Okay, moving on to the last part, that is your steps in interpretation. So whenever you're given an X-ray, your picture-based questions, no, whenever you're given an X-ray image, please analyze it in these 5 steps. Okay, first try to locate the abnormality, whether it is present in one particular area, whether it is localized or generalized, whether it is present in the maxilla or in the mandible, whether it's present on both sides of the maxilla or both sides of the mandible. Okay, so all these things comes under localizing the abnormality. Second thing is identifying the position, whether it is present coronal to the tooth. Either it can be present as a pericoronal lesion or a periapical lesion, or it can be present laterally, right? So locate where it is present, whether it is present above the inferior alveolar nerve canal or below the inferior alveolar nerve canal, present within the sinus. So identifying the position. Third thing is analyzing the shape or the periphery. Yeah, localizing the abnormality, like I mentioned to you, maxilla, mandible associated structures, whether it is unilateral, bilateral, or crossing the midline. See, one thing that we have to remember here is, in case of your crossing the midline and all, no, your OKC and all will try to cross the midline. And in case of expansions, I think expansions I'll tell you later. Okay. Generalized lesions or localized lesions. Generalized lesions mostly will involve your these things, the endocrine abnormalities, your Paget's disease and all that, no, that will be mostly generalized. But your localized lesions, like can be your cystic lesions or any kind of tumors, no, they'll be localized within that particular region alone. Yep, identifying the position, like I already mentioned to you, know, whether it is coronal to the tooth, in case of your dentigerous cyst or your ameloblastoma, and all, it can cover the entire impacted tooth, right? It is mostly odontogenic if it is coronal to the tooth. If it is present apical to the tooth, no, it can be sometimes non-odontogenic also. Okay, sometimes it will not be attached to the any the tooth surface at all. In case of cementosseous dysplasia and all, most commonly radio opacity will be present somewhere below the tooth surface, but the tooth will be completely vital. There will be no changes, no decay, no fracture. The tooth will be vital to your electropulp testing. So in such cases, it is non-odontogenic lesion. With the X-ray itself, you'll be able to tell, no, if it is odontogenic or non-odontogenic. Similarly, with your inferior alveolar nerve canal, no, if it is present above the IAC, it is odontogenic. If it is present below the IAC, it is non-odontogenic. Remember that, okay? Yep. If it is present within the nerve canal, no, like interrupting the course of the nerve, it can be neural or vascular in origin. That also you should remember. And sometimes the lesion can be present within the sinus. It can arise from a sinus pathology, some case of sinus tumors, or in case of any what is it called? Lith in the sinus. Sometimes, no, those kind of mucolith. Yeah, sometimes that can also be present. Okay, and the epicenters that is present within the maxillary alveolus in case of any tumors in the tuberosity region and all that. No, epicenter within the maxillary alveolus. Analyzing the periphery. The periphery can either be well defined or ill defined, right? So the well defined lesions in case of punched out borders, it can have, or corticated borders in case of a cystic lesion. Punched out as in case of multiple myeloma is only for the skull. For punched out in case of the jaw lesions, I think I would have mentioned, I'll tell you. Okay, and sclerotic margin, it is not clearly defined, right? It's just ill-defined margin. The sclerotic margin will be present, or a soft tissue capsule that is surrounding the lesion. This can also be present. I think in case of odontogenic myxoma, or no, not odontogenic myxoma, in case of a mixed lesion, mixed lesion where you have both the bony component as well as the soft tissue component, no, the soft tissue capsule will be seen enveloping the bony component, the radio opaque lesion. Okay, so I think fibroadenoma, something like that. In those lesions, you'll be able to define see this well-defined soft tissue capsule that is seen surrounding the radio opaque lesion. Okay, and in case of ill-defined margins, no, in case of any abscess and all that, no, the lesion will mostly have a blending border, as in the margin of the lesion will be blended with the surrounding trabecular bone. Okay, so blending border will be seen. In case of tumorous lesions or in case of cancers, no, invasive borders will be seen where the lesion will encroach into the other vital structures. So these are invasive borders. Okay, like I mentioned, no, the ill-defined margin in case of tumors, no, this is how it can involve the surrounding structures. Okay, looking at the shape of the lesion. Okay, analyzing the shape. We saw about the periphery. Now we are looking at the shape. So it can be either circular in case of cystic lesion or scalloped again in case of OKCs. It can have multiple locules that are attached together. No, so it gives a scalloping outline. So it can either be circular, that is in case of unicystic lesions, or scalloping borders can be seen. Looking at the internal structure being present. So based on the internal structure, it can either have air, fat or fluid, soft tissue, bone marrow, trabecular bone, a cortical bone or dentin, enamel or metallic structure. See, there are certain things that we have to remember. It can have a dead bone present within the lesion, radiolucent lesion, and can have a dead bone in case of osteomyelitis. We all know, right? Most common appearance of it. And the radiolucent lesions, if it is cystic, it can have either air or only when you do an aspiration you'll be able to see if it is air or fat or fluid, or sometimes it can have even pus discharge, right? So depending on the internal structure, the most radiolucent to most radio opaque, this is the categorization. Okay. So this is a completely radiolucent lesion, a completely radio opaque, as in case of odontome or any lith and all that. And then you have a mixed lesion, both radio opaque and radiolucent will be seen in case of your Paget's disease, your fibrous dysplasia and all that. Okay, analyzing the internal structure, like I already mentioned, it can be either unicystic or multicystic, right? So when it comes to a multicystic or a multilocular pattern, it can be present in certain patterns. Okay, first is your honeycomb pattern. Honeycomb, the difference between your honeycomb and your soap bubble, if you see, no, the locules in honeycomb will almost be similar. Okay, it will almost be of the same size, uniform pattern. Okay, in case of soap bubble, the locules will be, one will be small, one will be big. That is the difference between your honeycomb and your soap bubble. Both the patterns will be seen in case of your ameloblastoma. I'll tell you the DD of multilocular lesions in the other slides to come. Okay, and then your tennis racket appearance is again a DD of your multilocular lesion, where the septae are exactly at perpendicular angle, or they are perpendicular to each other. Tennis racket appearance is most commonly seen in case of your odontogenic myxoma. And then you have your scalloping margin, no, multilocular scalloping pattern seen in case of your OKC. Yep. So radio opaque and radiolucent. Radio opaque, if you see, no, it can give an appearance like a ground glass appearance in case of your fibrous dysplasia, or it can have a new bone formation here. Dead bone, that is your sequestrum, will be seen in case of your osteomyelitis, and septations within the bone or your loculi might also be present. Okay. So the radio-opaque lesions can be present like this. Amorphous bone will be present, or a tooth structure present within the bone in case of your odontome, your complex or your compound odontome. The difference between both, I hope you are already familiar, right? Complex is a disorganized mass of tissue, and a compound odontome will be almost similar to your tooth structure. It will have an enamel dentin and a pulp distinguished from each other. And dystrophic calcifications like your pulp stones that is present within the coronal or your radicular pulp. Okay, and the destructive patterns of bone lesions in case of your tumorous cells, no, you can see that large areas of lysis will be seen. Sometimes it will be seen as moth-eaten appearance, that is different small areas of destruction of bone will be seen. And permeative pattern is it will be completely infiltrating the bone with rapid area of destruction. These are the different patterns of destructive bone lesions in case of osteosarcoma, or in case of any bony lesions where the bone is completely being destructed, no, by the cancerous cells. So these are the patterns in which it can exist. Expansion of the cortical plate. See, expansion is very important when it comes to lesions like your dentigerous cyst or your ameloblastoma and all that. Sometimes the expansion can be unilateral, that is monocortical expansion or bicortical expansion can be seen. So it gives an crackling sound when you try to palpate the expansion of the cyst. And one more thing is, when it comes to expansion, it doesn't mean only the cortical expansion on both sides. See, the expansion of the cyst can be either through the cortex, that is buccolingually, or the extension can be mesiodistally. Okay, in lesions like OKC, the what is that, anteroposterior expansion will be most commonly seen. That is the distinguishing feature of your OKC. Okay, the cyst will expand or it will extend anteroposteriorly. On the other hand, the buccolingual or the buccopalatal expansion will be seen in cases of your amyloblastoma and all these things. Okay, so this is the characteristic feature of your OKC. One more thing. Okay, and destruction of cortical plates obviously up to the inferior border of mandible. Sometimes it can lead to fracture of the mandible also, right? So the destruction can be extensive in case of a rapidly progressing lesions, or in case of rapidly aggressive lesions like your OKC and all. Destruction of the cortical plates through and through can be seen. When you look at the effect on the surrounding structures, apart from the area of affect, I mean the area which is affected, no, the surrounding structures like your vital structures like your inferior nerve canal and the tooth adjacent to it can also be affected. So the tooth, sometimes resorption of the roots can be seen, or displacement of the teeth. There can be expansion of the cysts in such a way that there will be displacement of the tooth that is visible. Okay, so these two are the most common effects on the surrounding structures. Then you have PDL space, changes in the PDL space. There can be localized widening in case of smaller sized lesions, and in case of endocrine abnormalities and all I mentioned, right? So in such cases, no, a generalized widening of PDL space can also be seen. Okay, and the loss of lamina dura, it can be intact in case of, normally it should be intact, and it will be disrupted in case of localized lesions, and also in case of generalized disruption of your lamina dura can also be present. And your pedial space, no, your pedial space will also be lost in case of defects like your what is that, tooth fused bone, ankylosis. In ankylosis, also your loss of lamina dura and your pedial space will be absent. Okay, so in such cases also we should be able to locate the pathology. Apart from this, now we have something called as peripheral bone reaction. So this is nothing but new bone formation in response to the trauma or the injury or the pathology. So there is going to be a new bone that is present surrounding the pathology. Okay, there are different patterns in which this periosteal bone reaction can take place. For example, your onion skin appearance, as in case of your Gary's osteomyelitis, your sunburst appearance in case of your osteosarcoma. So these are the different ways in which your new bone will be formed in response to the injury, trauma, or the pathology. Okay, or the infection. Yeah, four main things. So these are the morphological classification of your periosteal bone reactions. Then moving on to your nerve, most importantly your inferior alveolar nerve canal. There can be displacement of the canal, enlargement or destruction. Okay, and if it is present through the nerve canal, then it can be a neuronal or vascular destruction, neuronal or vascular tumor that is causing the destruction of the canal. Okay. These are the differential diagnosis. I think I'll try to pass the PPT to you. So I have listed the differential aspects of each of the appearances. So in case if they give you any image-based questions, or if they give you any clinical scenarios, with the clues, you'll be able to identify what kind of a diagnosis it is. Okay. So periapical, most common periapical radiolucencies I have listed out, and pericoronal radiolucencies with radiopacity, without radiopacity. As in, with radiopacity means it will have a radiolucency surrounding a radio opaque abnormality. That is only with radiopacity. For example, your CEOT or AOT, which has an impacted canine, and then you have your odontome surrounding radio, I mean, with the surrounding radiolucency over it. So all these are with radiopacities. Without radiopacities, is going to be your amyloblastoma, your KCOT, dentigerous cyst, and all that. Okay. And then comes your multilocular radiolucencies, the most common ones, amyloblastoma, odontogenic myxoma. The characteristic difference that can most commonly be asked is they can give you a soap bubble appearance or a honeycomb appearance. And then that time you have to mention amyloblastoma, ABC, central hemangioma, your CG, cherubism, everything. Cherubism, remember, it will be bilateral, okay? It's like a generalized lesion, and mostly it is present only in children, okay? If they have given you an X-ray, an OPG X-ray with multiple deciduous teeth, and then they have mentioned about a clinical scenario, if they have mentioned about a young child, a chubby child, with multiple radiolucencies on the both sides of the jaw, then you have to think about cherubism only. You cannot think about ameloblastoma in that case, okay? So there are small differentiating features between the multilocular radiolucencies itself, okay? And for example, if they have given a picture with septae at right angles to each other, always remember odontogenic myxoma, okay? And then if they have given scalloping border very clearly, think about OKC, okay? So correlate with whatever is given, the image or the clinical scenario which is given. If it is a clinical scenario, see the key points, look for the key points, the age of the patient, the location of the lesion. So with these points, try to remember what can be the most probable diagnosis, okay? Poorly defined radiolucencies, a few things I have listed like chronic osteomyelitis, osteoradionecrosis of the jaw, your metastatic carcinoma, multiple myeloma, and all that. Generalized rarefaction is going to include your osteoporosis, your hypophosphatasia, and all that. Okay. And periapical radiopacities. Apart from periapical radiolucencies, you have periapical radiopacities that can be solitary or multiple. Solitary is going to include something that is confined to that particular tooth only, like an exostosis or a tori, condensing osteitis. See, remember when it comes to radio opacities, no, if you have a radio opacity that is surrounding a root of a tooth, uh, just see if the clinical scenario, if they have mentioned whether there is any presence of decay and the tooth is vital or not. This is applicable for your clinical diagnosis also. When you're practicing on a later day, a patient is coming with you. Incidentally, you're taking a radiograph, you're seeing some radio opacity below the apex of the tooth. You don't know if it is normal or abnormal, right? See, in case of condensing osteitis, definitely the tooth will have some pathological damage, okay? Odontogenic pathology will be present, either a decay or a fracture, or the tooth will be non-vital, okay? So with these three, if you see a radio opacity below it, a solitary radio opacity below it, blindfold, think about condensing osteitis. But if the tooth is vital, the radio opacity is still attached to it, means think of some kind of bony lesion, a non-odontogenic or a bony lesion like osteosclerosis, or it can be even a odontome also, who knows. Odentum will be slightly more radio opaque, but osteosclerosis and all, it's not very well defined. Okay. So that was about it. And then you have diffuse radiopacities, like I already mentioned, no, your endocrine abnormalities or even your Gardner syndrome with multiple radiopacities being present. And then your fibrous dysplasia, Paget's disease. I think your fibrous dysplasia, it has three different stages, where the initial stage it will be radio lucent, then it becomes radio opaque, and the final stage only it becomes a mixed radio opaque radiolucent lesion. You have to remember that also. And also the types of fibrous dysplasia, your periapical fibrous dysplasia, florid, and I think there is one more type if I'm not wrong. Please refer to all those things and remember all those, okay? Not fibrous, sorry, osseous dysplasia. Yep. And this is all I that we already mentioned. It's like a summary of the for coming to a final radiographic diagnosis. This is like a summary, okay? And I have listed a table for you with this was asked in MCQs many times, so I have listed like a table for you, okay? The most common features and the diagnosis for those features, okay? When ghost teeth, something mentioned about ghost teeth means, remember the diagnosis most commonly would be regional odontodysplasia. A heart-shaped radiolucency in the midline of the maxilla is median anterior maxillary cyst. Pear-shaped radiolucency corresponds to a globular maxillary cyst. Shell teeth corresponds to type 2 dentinogenesis imperfecta, and thistle tube of pulp chamber is correlating with the type 2 dentin dysplasia. Okay, this one I already mentioned to you, right? A soap bubble appearance, most commonly seen. The DD is going to be ameloblastoma, ABC, OKC, central hemangioma. Tennis racket apparent, odontogenic myxoma. Yep, okay. We're almost closing it. Yeah, I think I'm almost done. Okay, maybe I'll just pass the slides to you. These are the differential diagnosis and the key features that I have mentioned. Please go through it and then try to remember, okay? A little about the artifacts also I had mentioned, the most common causes and the errors that is present, okay? So in case you have any doubts, you can let me know in the group. I can help you out. Try to remember the key points, and picture-based questions also try to read properly, okay? And differential diagnosis is very, very important in case of picture-based questions. We'll stop the class with this. Thank you so much. All the best.